acceptable lexicon. If it's hemorrhagic cyst, we can use the retracted clot, reticulations, fluid levels. And regarding septations, we should comment if it's incomplete, thin, thick, thin if it's less than 3 millimeter, thick if it's more than 3 millimeter. And if there is an internal solid component, which include papillary projections that is more than a millimeter, and if the number of the papillary projections is more than 4, there is a high risk of malignancy, and if there is a smooth solid component or irregular component. So this is the grading score for the vascularity. It's a little bit of a subjective, that's the reality, but score A or score 1 is very minimal vascularity. Score 2 is a little bit more. Score 4 is when you have a very vascular lesion, and score 3 is somewhere between B and D. Regarding extra-ovarian findings, if there is a peritoneal inclusion cyst, we can just name it as it is. If there is a para-ovarian cyst, we should apply the ORADS lexicon. Fallopian tube descriptors are incomplete septation or tubular or endosalpingeal folds. And regarding the free fluid, we should use the term ascites if the fluid is extending above the fundus and an anteverted uterus, and if it's between the uterus and the urinary bladder and a ureteroverted uterus. If it's only within the cul-de-sac, so it's only fluid in the cul-de-sac. And we should also comment if the fluid is clear versus with debris. We should comment also on if there is a peritoneal thickening, nodularities, if it's focal versus diffuse, if there is a serosal deposits, and also if there is an adenopathy. So regarding the management for these patients, it depends on whether the patients are premenopausal or postmenopausal. In ORADS 1, there is no recommendation, no follow-up is required. If it's ORADS 2, it depends on the size. If it's less than 3 centimeter, no follow-up is required for both group. If it's less than 5 centimeter, no required follow-up for the premenopausal ladies, but there is a required follow-up to at least 1 year for postmenopausal ladies. And for premenopausal, the follow-up is recommended to be between 8 to 12 weeks. And if it's a non-simple unilocular cyst with smooth inner margin, depends on the size as well. If it's less than 3 centimeter, no follow-up is needed for the premenopausal group. But for the postmenopausal, we need the follow-up at least once in a year by a ultrasound specialist or MRI. What do we mean by an ultrasound specialist? Is a physician that is experienced in assessing adnexal lesions with ultrasound. So if this guy is not available, MRI would be fine. Regarding ORAD 3, 4, and 5, all require management or follow-up. In ORADS 3, the required follow-up is by ultrasound specialist or MRI and to be managed by gynecologist, whether in ORADS 4 and 5 they should. So let's apply some ORADS lexicon. So here you can see a simple cyst with a very vascular ring. So it is physiological, it's not hemorrhagic, it's not follicular. Follicular cyst should not have a thickened wall. And it's not a lesion, of course, it's physiological. For this one, why it's not physiological? Because it's more than 3 centimeter. So it's a lesion, but it's a simple cyst, and it's a unilocular cyst with no solid components. It's not a corpus luteal cyst. And this is an example for a color score 2. You can compare it with this vascular irregular lesion. So when we try to apply the lexicon, we should not call it a cystic with irregular solid components, because we said if the lesion is having more than 80% solid components, it's already a solid mass. The outer contour is irregular. There's internal vascularity, yes. Peripheral vascularity, actually ORADS doesn't care if the vascularity is peripheral or central. So since there is vascularity, so we just scar it and that's it. So this is the reticular pattern typical for hemorrhagic cysts. This is the typical retracted clot, also typical for hemorrhagic cysts. This is our famous low-level echoes, or the ground glass lesion, typical for endometrioma. And here we have our cute floating guys, the floating hyperechoic spherical structures, which is typical for dermoid. So now going to a more interesting section, which is the MRI. But I just want to remind you of some governing concepts on applying the ORADS in MRI. Again, it assumes an average risk patient with no acute symptoms. In case of multiple or bilateral lesions, management is according to the lesions with highest score. Regarding benign mature teratomas or dermoids, they are typically ORADS 2. Septations, like thin septations or Rokitansky nodule, which is usually enhancing, would not upgrade the dermoids to ORADS 4. What does upgrade it to ORADS 4 is a very large soft tissue component. And if we have few characteristic lesions with typical feature, we can just go ahead and name them regardless of the ORADS, such as dysgerminoma, granulosa cells, and etc. And just be reminded that to apply the ORADS, it's optimally to have a dynamic contrast enhancement with a time resolution of less than 15 seconds. So now a crazy table again, but we were not going to bother ourselves. This is a simplified table. Again, ORADS 1, our physiological things. ORADS 2 is when we have simple cyst, hemorrhagic cyst, endometrioma, typical things, dermoid also. And additional thing is the dark soft tissue component is under ORADS 2. We will have examples in the few slides which can make things more clearly. And in ORADS 3, we have the multilocular cyst with no soft tissue, or a soft tissue, but it should have a low risk enhancement curve. And please do not mistake this one with an enhancement that is less than the myometrium. We need to have a dynamic to assess the risk, the enhancement curve. I will show you a figure of what I mean. And ORADS 4 is when we have a dermoid with a large amount of soft tissue. If we have any type of cyst with a solid tissue that have an intermediate risk enhancement curve or enhancing less or equal to the myometrium. ORADS 5 is when we have a frank solid tissue with high risk enhancement curve or enhancing more than the myometrium. And of course, if we have ascites, peritoneal thickening, or nodularity. So this is the curve. Here we can see the myometrium curve. Here is the low risk enhancement curve. It's something that enhances in a progressive pattern. Here is the high risk. It's something that is hypervascular with washout. And here is the intermediate risk enhancement, something that is enhancing less than the myometrium, but it's not progressive. So in summary, we use the word physiological if we have simple or corpus luteum cysts. We use lesions if they could be either unilocular, multilocular, plus, minus a solid components. Don't forget the fluid descriptors. And also if we have a solid tissue, which include papillary projections, mirror nodules, irregular septation, or other larger solid portions, and also the enhancement score. So now we'll have some cases that I've collected from my institution. Okay, so here we have bilateral adnexal lesions. Here you can see a thickened wall that is briskly enhancing. Here is another lesion. You can see the reticulation, the very dark signal intensity on T2 weighted images. This patient actually had a prior ultrasound that was, for me, more clear than the MRI. We can see here a simple cyst and a typical reticulation, which is typical for hemorrhagic cysts. And such cases are why ORADS is an important thing to apply, because this patient didn't need to be followed for only physiological things, but lucky us that we could see how hemorrhagic, simple cyst, corpus luteum cyst look on MRI and ultrasound. So this is ORADS 1, corpus luteum, simple or hemorrhagic cyst. This is a typical ring of fire of the corpus luteum cyst, and again, this is how it appears on MRI. I'm sure everyone is familiar with. So again, ORADS 1. Here is the simple cyst on ultrasound, smooth outlines. Again, on MRI, it's smooth outlines, no septation, no solid components, but it's not adnexal. This was a para-ovarian cyst. And yes, we do apply the ORADS on a para-ovarian cyst once we are really sure about the origin. So this was ORADS 2, simple cyst. Here we have our famous low-level echoes, high T1, shading on T2, endometrioma, ORADS 2. Another example of endometrioma, bright T1, shading on T2, endometrioma, ORADS 2. Here, this is a patient presented with this 7-centimeter mass with the floating spherical hyperechoic lesion. She did an MRI. There was a typical drop on signal intensity of the outer phase. So it was typical dermoid, ORADS 2. So here also bilateral lesions. This one is clearly a simple cyst. This one is showing a very dark signal on T1, very dark signal on T2. It is almost like 80% solid, but the solid component is our dark guy, so this should not be ORADS 3, this is ORADS 2. Our dark guy is always ORADS 2. So this was surgically and pathologically confirmed fibroma.